All right, everyone, we'll get started. I apologize in advance. I'm getting over a cold, so I do have a little bit of a cough. I may need to mute myself. I'll show this same screen at the end of the presentation too, if you need another minute to put in the code. So the title of my presentation is Treatment of Cancer-Associated Thrombosis, or DOACs, the new low molecular weight heparin. I'd like to thank my content expert, Sydney Bringold, who helped me with this presentation. And so we have 4 objectives today. The first objective is to explain the incidence, pathophysiology, and risk factors for cancer-associated thrombosis. Next, we'll summarize the historical data supporting the use of low molecular weight heparin. Third, we'll analyze the data regarding use of DOACs compared to warfarin and low molecular weight heparin in cancer-associated thrombosis. And then fourth, we'll discuss guideline recommendations in relation to publication of DOAC studies and select appropriate VTE treatment based on patient, cancer, and treatment-specific factors. And so starting with the first objective of explaining the incidence, pathophys, and risk factors for cancer-associated thrombosis. Cancer-associated thrombosis can be defined as VTE that is attributed to cancer and anti-cancer therapies. There are a lot of variations to this definition out there, but this is a commonly utilized definition that we'll use for the purposes of this presentation, and also because many of the studies I'll describe focus on VTE treatment specifically. Cancer-associated thrombosis is the second leading cause of death in cancer patients after disease progression. Patients with cancer are 4 to 7 times more likely to develop VTE than patients without cancer. And you might be surprised to know that 20% of all VTE occurrences happen in patients with cancer. And so it's generally recognized that cancer and thrombosis are linked by multiple molecular mechanisms. It's also known that in addition to patient-specific factors, both cancer and treatment-associated factors impact coagulation to increase thrombosis risk, and I'll spend a little bit of time going through these mechanisms. So we'll start with molecular mechanisms of cancer-associated thrombosis. Patients with cancer are generally in a hypercoagulable or prothrombotic state, and the increased risk of thrombosis is associated with all 3 components of Virchow's triad. This includes abnormalities in blood flow, which can occur due to bed rest and immobility, and also sometimes extrinsic compression of blood vessels by tumors. This also includes injury to the vascular endothelium, which can occur from direct tumor invasion, chemotherapy, anti-angiogenic inhibitors, and also indwelling catheters. And these patients are also at a hypercoagulable state due to tumors and macrophages producing procoagulants and inflammatory cytokines, as well as the use of erythropoietin stimulating agents. And I'll talk about those mechanisms in a little bit more detail on the next slide. So in addition to cancer and treatment-associated factors, there are a number of other molecular mechanisms that predispose cancer patients to thrombosis by directly activating coagulation and platelets. Tissue factor, or TF, is a transmembrane receptor that initiates the extrinsic coagulation cascade pathway and causes thrombin generation and platelet activation. Many cancer types express tissue factor, and this may contribute to increased risk of thrombosis. Tumor cells also release tumor microparticles, which are small procoagulant membrane vesicles, and these tumor microparticles also express tissue factor. There's evidence to show that patients with cancer have elevated levels of these tissue factor positive microparticles, and these contribute to increased thrombosis risk. Another possible contributor to cancer-associated thrombosis is cancer procoagulant, or CP, which is found almost exclusively on malignant cells. CP is a cysteine protease that activates factor 10 without needing factor 7 and is believed to contribute to increased thrombosis risk. Tumor cells may also express podoplanin, which can bind to platelet receptors to cause platelet activation and aggregation. This is known as tumor cell-induced platelet activation. And finally, tumor cells may express plasminogen activation inhibitor 1, which inhibits fibrinolysis, and it's also been shown that pancreatic cancers highly express PAI1. And so these are some of the molecular mechanisms by which cancer patients may be predisposed to thrombosis. And it's important to remember that different cancer types may have varying expression of these molecular markers. There are also a number of cancer-associated risk factors for cancer-associated thrombosis. First, the primary site of cancer is a risk factor for VTE, and it's agreed that VTE incidence is not the same among different cancer types. For example, stomach and pancreatic cancers carry some of the highest VTE risks. Next, cancer stage is also a VTE risk with more advanced stages of cancer, particularly metastatic cancers carrying the highest VTE risk. In a population-based cohort study, it was shown that relative risk of VTE increased with increasing cancer stages, with stage 1 having a VTE relative risk of 2.9% and stage 4 having a relative risk of 17.1%. And then next, for some cancer types, the histological subtypes of that cancer may carry increased VTE risks. For example, lung and ovarian cancer subtypes carry varying cancer-associated thrombosis risks. And then finally, the time after diagnosis can impact cancer-associated thrombosis risk factors. And the time immediately after cancer diagnosis has the highest risk, likely due to factors related to cancer therapies. Some studies report that the highest risk is within 3 to 6 months, and others report that the highest risk is within the first year. And although the scope of this presentation is treatment of cancer-associated thrombosis and not VTE prophylaxis, I did want to briefly show the Khorana risk score, which is a well-known risk stratification tool that assesses VTE risk in cancer patients to help guide which patients would benefit from VTE prophylaxis. And I wanted to highlight that the site of cancer is one factor in this risk assessment tool. And as you can see, again, that stomach and pancreatic cancers carry the highest VTE risks, followed by lung, lymphoma, gynecological, bladder, and testicular cancers. There are also a number of treatment-associated risk factors for cancer-associated thrombosis. VTE is a common complication of surgery, but patients with cancer are at an increased VTE risk post-operatively than those without cancer, particularly in pelvic and abdominal surgeries. However, these risks are improving due to improvements in perioperative care. Next, chemotherapy itself can carry an increased thrombosis risk. There are many types of chemotherapies that are associated with increased VTE risk, including cisplatin, which is a platinum-based chemotherapy used in several cancer types. And then next, there's evidence to show that certain angiogenesis inhibitors increase thrombosis risk, particularly the agent bevacizumab, which has been shown to increase arterial thrombosis risks. And then finally, we know that central venous catheters increase risk for catheter-related thrombosis for any patient. And in cancer patients, central venous catheters are often necessary for a number of aspects related to cancer therapies. As we're all probably aware, the initial recommendations for treatment of cancer-associated thrombosis were to use low molecular weight heparin. And so now we'll summarize the historical data that supported use of low molecular weight heparin over warfarin. There are 4 major trials that supported the use of low molecular weight heparin over warfarin for prevention of recurrent VTE, and these are the Canthanox, CLOT, LIGHT, and CATCH trials. For all of the trials, low molecular weight heparin was compared to warfarin with an INR goal of 2 to 3, and all patients treated with warfarin were bridged with low molecular weight heparin. The duration of follow-up was between 3 to 12 months for the trials, and the primary outcome was the rate of recurrent VTE. Remember, these trials were done in patients who already had a clot, and so we're looking at recurrent VTE rates, and we're not looking at VTE prophylaxis in patients without clots. These studies found that low molecular weight heparin reduced the risk of VTE or recurrent VTE by 30 to 56% relative to warfarin, and reduced the absolute risk by 3.1% to 9% overall. I also wanted to include the actual VTE rates for treatment groups on this slide, so if you're interested in referencing this later, you can. Also, in terms of safety, there was no significant difference in major bleed events in all 4 trials. And so this data supports use of low molecular weight heparin over warfarin in cancer-associated thrombosis due to reduction in recurrent VTE rates, no differences in major bleeding, and as we know, there are fewer drug-drug interactions with low molecular weight heparin as compared to warfarin. So we know that evidence supports use of low molecular weight heparin over warfarin, and this may not come as a surprise, but adherence to low molecular weight heparin can be quite poor. There are several studies that have found that long-term adherence with low molecular weight heparin is lower than that with warfarin. In the TICAT study, which was a prospective study evaluating tenazepam safety, 25 patients did not complete the intended 6 months of therapy. In the DOACs study, there was which was a prospective study evaluating recurrent VTE in patients with dalteparin. 50% of patients did not complete the intended 12 months of therapy. Possible reasons for poor adherence to low molecular weight heparin could be due to the negative impact on life with daily sub-Q injections, and also possibly due to the high cost of low molecular weight heparin compared to warfarin. It's also important to note that dropout rates are likely higher in real-world clinical settings as randomized controlled trials are highly controlled and well-designed. So although evidence suggests that low molecular weight heparin is more effective than warfarin for cancer-associated thrombosis, poor adherence to low molecular weight heparin makes us wonder if DOACs would be an appropriate treatment choice for cancer-associated thrombosis. So we'll move on to our third objective of analyzing the data that compares DOACs to warfarin and low molecular weight heparin. I'll first summarize the data that compared DOACs to warfarin, and these trials are a bit older. They were published between 2009 and 2014. These were the major trials that first supported the use of DOACs, and this includes the Einstein DVT and Einstein PE trials, the Recover and Recover 2 trials, and the Amplify and Hokusai VTE trials. I'll then go into more detail on the newer trials that compared DOACs to low molecular weight heparin. These trials were published between 2018 and 2020 and were incorporated into the newer cancer-associated thrombosis guidelines that I'll also go through in this presentation. And these trials include the Hokusai VTE cancer trial, SELECT-D, ATOM VTE, and the Caravaggio trials. So we know that low molecular weight heparin is more effective than warfarin, and we also know that low molecular weight heparin has poor long-term adherence, but what did the older data regarding DOACs versus warfarin tell us? So in 2015, there was a network meta-analysis of phase 3 studies using DOACs for cancer-associated thrombosis, and here I'm presenting the data from a sub-analysis of this network meta-analysis that compared DOACs to warfarin. And although this presentation is more of a comparison between DOACs and low molecular weight heparin, I felt that this data was important for completeness. And so if you're interested, this network meta-analysis did complete an indirect network comparison between DOACs and low molecular weight heparin as well. And so we have our 4 trials here. The Einstein trials assessed rivaroxaban use. The Recover trials assessed dabigatran use, and the Amplify trial assessed apixaban use, and the Hokusai VTE trial assessed edoxaban use. In all of the trials, DOACs were compared to warfarin, again bridged with low molecular weight heparin, and targeted an INR of 2 to 3. The duration of follow-up was between 3 and 12 months, and the primary outcome was recurrent VTE or VTE. These studies found that DOACs reduced the risk of VTE or recurrent VTE by 30% to 48% relative to warfarin, and reduced the absolute risk by 1.6% to 3.4% overall. In terms of safety, DOACs had a non-significant 28% lower risk of major bleeding compared to warfarin. As with any trial, there were some limitations to these trials. One limitation with these trials was that they were inconsistent with their definition of cancer status. These trials also excluded patients with reduced life expectancy or those with a higher bleed risk. And the combination of these two things likely led to a patient population that was lower risk than the trials comparing low molecular weight heparin to warfarin that I presented previously. And so therefore, we needed prospective randomized controlled trials to support the use of DOACs over warfarin and low molecular weight heparin. And we'll now review the randomized controlled trials that looked at DOACs compared to low molecular weight heparin for treatment of cancer-associated thrombosis. So in our first trial, the Hokusai VTE cancer trial, this was published in 2018. This is a randomized open-label non-inferiority trial. They enrolled patients with cancer-associated thrombosis and enrolled a little over 1,000 patients. They compared edoxaban at treatment dosing with a low molecular weight heparin run-in to dalteparin at treatment dosing for a duration of 6 to 12 months. The primary endpoint was composite of recurrent VTE or major bleeding, and this was found to be non-inferior between edoxaban at 12.8% and dalteparin at 13.5%. This gives us a hazard ratio of 0.97 and a p-value of 0.006 for non-inferiority. And I did separate the composite endpoint to their individual components. So the rate of recurrent VTE was not significantly different with edoxaban at 7.9% compared to dalteparin at 11.3%. And then the rate of major bleeding was significantly higher with edoxaban at 6.9% compared to dalteparin at 4.0%. And this was a hazard ratio of 1.7 with a p-value of 0.04. I want to mention that the increased risk of major bleeding was primarily a result of higher rates of upper GI bleeding in patients with GI cancers. Major bleeding rates for patients with GI cancers treated with edoxaban and dalteparin were 12.7% and 3.6% respectively. And so the authors concluded that edoxaban is non-inferior to dalteparin for the composite outcome of recurrent VTE and major bleeding. I also want to mention that the median duration of therapy was significantly shorter with dalteparin than with edoxaban, mainly due to patient preferences to stop dalteparin. And this is just to reiterate the point that low molecular weight heparin tends to have poor adherence. So the next trial is the SELECT-D trial, which was published in 2018. This is a multi-center randomized open-label phase 3 pilot study that enrolled a little over 400 patients. The intervention group received rivaroxaban at treatment dosing, and the control group received dalteparin, and this was for a duration of 6 months. The cumulative rate of recurrent VTE was lower with rivaroxaban at 4% than with dalteparin at 11%. And this was a hazard ratio of 0.43 with a relative risk reduction of 56% and an absolute risk reduction of 5%. The cumulative rate of major bleeding was higher with rivaroxaban at 6% than with dalteparin at 4%. And similar to the previous trial, most major bleeding events were localized to the GI tract in patients with gastroesophageal cancers. And so in conclusion, rivaroxaban is associated with relatively low VTE recurrence, but higher major bleeding and clinically relevant non-major bleeding compared with dalteparin. And I also want to mention that there was a high censoring rate due to high mortality, and only 54% of patients completed the first part of the study, which lasted that 6 months. And so the second stage of the study, which was planning to evaluate extended rivaroxaban treatment, was closed. The third trial is the ATOM VTE trial, which was published in 2020. This is a randomized, open-label, investigator-initiated trial. They enrolled 300 patients. The intervention group received apixaban at treatment dosing, and the control group received dalteparin at treatment dosing, and this was for a duration of 6 months. The primary endpoint is the rate of major bleeding between 6 and 12 months. This study is unique in that the primary outcome is the rate of major bleeding, but I will report on both major bleeding and recurrent VTE. The rate of recurrent VTE was less in patients receiving apixaban at 0.7% than dalteparin at 6.3%, and this is a hazard ratio of 0.09 with a p-value of 0.02. This is a relative risk reduction of 90% and an absolute risk reduction of 5.6%. For bleeding, the rate of composite of major bleeding and clinically relevant non-major bleeding was similar between the two groups at 6%. And in conclusion, apixaban is associated with lower VTE recurrence and similar major bleeding in patients with cancer-associated thrombosis. And I want to mention that there were fewer patients with upper GI cancers included in this trial as compared to the Hokusai VTE cancer trial, the SELECT-D trial, and the Caravaggio trials. So that's something to keep in mind when we're looking at the major bleeding outcomes in this trial. The ATOM VTE trial also assessed quality of life using a survey of questions that asked a variety of questions about medication side effects, stress, and satisfaction and confidence. At baseline, there was no significant difference in any of the questions when comparing the two treatment groups, and any differences at the end of the study are highlighted in yellow or red. The yellow boxes are survey questions where apixaban was favored. The white boxes are survey questions where neither apixaban nor dalteparin were favored, and the red boxes were survey questions where dalteparin was favored. As you can see, the overall burden and negative impact on overall quality of life was significantly higher with the dalteparin group. Interestingly, the only question that favored dalteparin was regarding confidence that the drug protected the patient from clots. However, this data adds support to the notion that low molecular weight heparin is associated with poor adherence due to many of the reasons addressed in this survey. I'll also mention that more patients who were randomized to receive dalteparin in the ATOM VTE trial stopped therapy early as compared to the apixaban treatment group in this trial. And then the fourth trial is the Caravaggio trial, which was published in 2020. This was a multinational, randomized, investigator-initiated, open-label, non-inferiority trial that enrolled just over 1,100 patients. The intervention group received apixaban at treatment dosing, and the control group received dalteparin at treatment dosing, and this was for a duration of 6 months. The rate of recurrent VTE was less in patients receiving apixaban at 5.6% than dalteparin at 7.9%. And this is a hazard ratio of 0.63 with a p-value of 0.001, which is significant for non-inferiority. And then this gives us a relative risk reduction of 34% and an absolute risk reduction of 2.3%. For major bleeding, there were no significant differences in major bleeding between the apixaban group at 3.8% and the dalteparin group at 4.0%. And I'll just mention that only 4.7% of patients in this trial had GI cancers, which could possibly contribute to the major bleeding findings from this trial. So these authors concluded that apixaban is non-inferior to dalteparin for treatment of cancer-associated thrombosis without an increased risk of major bleeding. And so both the ATOM VTE trial and the Caravaggio trial compared apixaban to low molecular weight heparin, but the ATOM VTE trial showed significant reduction in recurrent VTE. And so we should probably compare the patient populations between these two trials. The Caravaggio study had a higher proportion of patients with higher ECOG scores, which is a measure of a patient's functionality, and perhaps this impacts the risk of VTE, as patients in the Caravaggio trial had a poorer functionality score. The Caravaggio trial is also a much larger trial that enrolled about 1,100 patients, whereas the ATOM VTE trial enrolled 300 patients. And so these are potential reasons why the ATOM VTE trial may have shown significant reductions in recurrent VTE, and the Caravaggio trial showed non-inferiority. I'll also mention that both trials had a similar proportion of patients with metastatic disease. Between 65 and 68% of patients had metastatic disease. And I wanted to point this out because, as you recall, the previous DOAC trials may have selected for lower risk patients. So there are some comparisons and considerations we can make from these DOAC trials. When we compare the randomized control trials, we see that there are higher rates of GI bleeding in patients with GI and GU cancers, and therefore guidelines recommend to use DOACs with caution in these patients. The NCCN guidelines specifically call out that apixaban may be safer than edoxaban or rivaroxaban for GI and GU cancers. I also want to comment that over half of the patients in these randomized controlled trials had metastatic disease, and we know that patients with metastatic disease have approximately 20-fold increased VTE risk compared to patients without cancer. And this helps us understand that these trials, unlike the previous DOAC trials, didn't select for lower risk patients. These trials also frequently use the International Society on Thrombosis and Hemostasis, or ISTH, major bleeding definitions, which includes a hemoglobin drop of greater than 2, or the patient requires 2 or more units of whole blood or RBCs. Anti-cancer therapies themselves often decrease hemoglobin and require blood transfusions, and so it's been recommended by some reviewers that trials reevaluate the applicability of the ISTH definitions when assessing the safety of DOACs in cancer-associated thrombosis. So we'll now move on to the fourth objective, which is to review guideline recommendations in relation to publication of DOAC studies and also apply these recommendations to a patient case. Guideline recommendations for cancer-associated thrombosis come from 4 organizations, and this includes the International Initiative on Thrombosis and Cancer, or the ITAC, the American Society of Clinical Oncology, or ASCO, the American Society of Hematology, or ASH, and the National Comprehensive Cancer Network, or NCCN. So when reviewing the guidelines, it's important to understand which trials were published in relation to guideline updates. We'll first review the ASCO and ITAC guidelines, which were updated in 2019. At that time, the Hokusai VTE trial that evaluated edoxaban use and the SELECT-D trial, which evaluated rivaroxaban use, were published. It's important to note that the ATOM VTE and Caravaggio trials that evaluated apixaban use were not published at this time. So starting with the ASCO guideline recommendations, for initial anticoagulation, the ASCO guidelines recommend low molecular weight heparin if creatinine clearance is greater than 30, unfractionated heparin, fondaparinux, or rivaroxaban, and also low molecular weight heparin is preferred over unfractionated heparin for the first 5 to 10 days if the patient does not have renal impairment. For long-term anticoagulation, the ASCO guidelines recommend low molecular weight heparin, edoxaban, or rivaroxaban for at least 6 months, and this is preferred over warfarin due to improved efficacy. The guidelines also state that warfarin is known to be inferior but may be used if low molecular weight heparin or DOACs are inaccessible. They also call out that there's an increased risk for major bleeding with DOACs, particularly in patients with GI and GU malignancies, which we've kind of been talking about throughout this presentation. The ASCO guidelines also recommend that DOACs should be used with caution in patients with high risk for mucosal bleeding. And then finally, the guidelines recommend that drug-drug interactions should be reviewed when initiating DOACs, which is something that any good pharmacist is already doing. So moving on to the ITAC guideline recommendations, for initial anticoagulation, low molecular weight heparin is recommended for initial VTE treatment when creatinine clearance is greater than 30, and this is a grade 1B recommendation. For patients without a high risk for GI or GU bleeding, including those without GI or GU cancers, rivaroxaban and edoxaban can be used for initial VTE treatment when creatinine clearance is greater than 30, and this is also a grade 1B recommendation. And then finally, unfractionated heparin can be used for initial VTE treatment when low molecular weight heparin or DOACs are contraindicated or unavailable. For long-term anticoagulation, low molecular weight heparin is preferred over warfarin when creatinine clearance is greater than 30, and this is actually a grade 1A recommendation. These guidelines also do call out that daily sub-Q injections with low molecular weight heparin may be burdensome to patients, and I found that interesting. ITAC guidelines also recommend DOACs when creatinine clearance is greater than 30 in the absence of strong drug-drug interactions or GI absorption concerns. They also recommend DOACs should be used with caution in patients with GI malignancies, especially upper GI malignancies. I want to point out that the recommendation to use DOACs does not call out a specific DOAC to use, but does state that the available studies showed increased GI bleeding with edoxaban and rivaroxaban in patients with GI malignancies. They also call out that the data for use of other DOACs is needed to assess GI bleeding risk, as other agents may have different risk profiles and they're not the same between DOACs. And then finally, the ITAC guidelines recommend that low molecular weight heparin or DOACs should be used for a minimum of 6 months, and then after 6 months, termination or continuation of anticoagulation should be based on individual evaluation of the benefit-risk ratio, tolerability, drug availability, patient preferences, and cancer activity. So we've covered ASCO and ITAC guideline recommendations after the publication of the edoxaban and rivaroxaban trials. Now let's fast forward to the 2021 NCCN and ASH guideline updates that incorporated the ADAM-VTE and Caravaggio apixaban trials as well. So we'll first move on to the NCCN guideline recommendations. In general, the NCCN guidelines recommend DOACs or low molecular weight heparin over warfarin. The NCCN guidelines more specifically separate recommendations for patients without gastric or gastroesophageal lesions and patients with gastric or gastroesophageal lesions. So for those patients without gastric lesions, DOACs are preferred with apixaban and edoxaban both having Category 1 recommendations. Rivaroxaban is also recommended, and this is a Category 2A recommendation. For patients with gastric or gastroesophageal lesions, low molecular weight heparin is preferred. Dalteparin has the highest quality of evidence. If you recall, all of the newer DOAC trials compared DOACs to dalteparin, and therefore dalteparin is the only low molecular weight heparin approved by the FDA for this indication, and therefore has a Category 1 recommendation from NCCN. However, enoxaparin may also be used, and this is a Category 2A recommendation. So although low molecular weight heparin is preferred over DOACs in patients with gastric or gastroesophageal lesions, we know that barriers to low molecular weight heparin use do exist, and so NCCN guidelines do comment that apixaban may be safer than rivaroxaban or edoxaban for patients with gastric or gastroesophageal lesions, and this has a Category 2B recommendation. Finally, the ASH guideline recommendations. For initial anticoagulation during the first week, ASH guidelines recommend use of low molecular weight heparin or DOACs and specifically recommend apixaban or rivaroxaban. They also recommend low molecular weight heparin over unfractionated heparin for initial anticoagulation. For long-term anticoagulation, which they define as 3 to 6 months, the ASH guidelines recommend DOACs, specifically apixaban, edoxaban, or rivaroxaban, over low molecular weight heparin. They also recommend low molecular weight heparin over warfarin, which is consistent with previous recommendations. And then finally, for patients requiring treatment longer than 6 months, the ASH guidelines recommend DOACs or low molecular weight heparin. So we'll move on to our patient case. MV is a 65-year-old male with esophageal cancer who presented to the ED with chest pain, dyspnea, and cough. His heart rate is 110, blood pressure is 137/84. He's satting at 91%, and weight is 81 kilos. His serum creatinine is 0.9 with a creatinine clearance of 94. His D-dimer is 2150. ALT and AST are within normal limits. Hemoglobin is 10.6 and platelets are 370. He had imaging done and his BQ scan shows high probability of PE. So given imaging findings and high clinical probability of PE, MV is diagnosed with a PE. And so the question is, which of the following anticoagulation therapies is most appropriate for treating MV's PE per guideline recommendations? There's A, warfarin with an INR of 2 to 3. B is enoxaparin 1 mg per kg BID. C is apixaban at our usual treatment dosing. And then D is rivaroxaban at our usual treatment dosing. And then I repeated the case characteristics on the side of the screen. So please enter your answers into the chat. All right, so I see a lot of C's. The answer is actually B, enoxaparin at 1 mg per kg BID. The key point here is that the patient has esophageal cancer and is at a high bleed risk. So per the NCCN guidelines, low molecular weight heparin is preferred over DOACs in patients with gastroesophageal malignancies. Remember, although guidelines support use of DOACs, they should be used with caution in patients with GI or GU malignancies. However, if this patient wasn't able to give sub-Q injections or wasn't able to afford low molecular weight heparin, apixaban would be an appropriate alternative with close monitoring for bleeding. So some key takeaways: anticoagulation for cancer-associated thrombosis therapy should be based on unique patient-specific factors such as labs, disease-specific factors such as primary tumor type, and treatment preferences such as strong preferences to not give daily sub-Q injections. Other examples for considerations include medication coverage, renal function, adherence, and drug interactions. We've also known for a while that low molecular weight heparin is preferred over warfarin and is associated with a lower bleeding risk compared to warfarin. And then more recent data has supported use of DOACs in select populations. And then as a reminder, guidelines recommend against using DOACs in patients with GI and GU cancers given the higher bleed risk in the available evidence. And then finally, I wanted to share a really cool resource that can be accessed going forward as more studies are published. This is a living, interactive, systematic review and network meta-analysis that was launched in 2019. And as you can see, it includes the major trials we discussed. This interactive systematic review will also incorporate future trials as that data becomes available. And the link to the website is on the screen. This website also has the ability to analyze data in a lot of different ways, including an interactive table where you can filter based on different trial and population characteristics. You can generate filtered analyses and also create evidence maps. And so I would recommend accessing this resource as more data is published in order to assess it against some of the already published studies. There are 2 trials pending. The priority trial is assessing rivaroxaban and apixaban use against dalteparin in upper GI, hepatobiliary, and pancreatic cancers, with the primary outcome being clinically relevant bleeding. And then there's also the CONCO 011 trial that aimed to assess rivaroxaban compared to low molecular weight heparin, but this trial was actually terminated due to low recruitment. And then finally, there are 2 studies published in 2021 that I did not talk about. The first is the Canvas trial, which I chose not to include because there was not a specific DOAC that was studied, and instead they looked at multiple DOACs. And then there's also the Casta Diva trial that I didn't include because there was not enough enrollment to assess non-inferiority, and the duration was only 3 months, whereas the other newer studies had a duration of at least 6 months. But I did want to at least mention that these trials exist in case you're interested in looking at this data. And so with that, I will take any questions, and then the text code is on the screen.